So we've, I like to think that we've saved the best for last. You know, if you've been coming to these conferences for a while, that my being a health economist, I invite other health economists to come speak. And this time we're venturing a little bit far afield. I'm delighted that we were able to get Paul Howard from the Manhattan Institute to come speak to us today about Republican options for health care reform. As you know, as David Howard mentioned, and they are not brothers, so he's not, you know, pushing his own sibling. But Paul Howard had a terrific op-ed about drug prices in the Wall Street Journal just yesterday. And if you read op-eds in USA Today and Forbes magazine and other top national media outlets, you will see Paul's name. And it's terrific to be collaborating with another think tank in terms of doing a talk like this, because the Manhattan Institute is another what we like to think middle of the road, sort of moderate political views, which we wish the rest of the country was, but clearly isn't right now. But I think he's going to give what you're going to find is a very informative talk about Republican options for health care reform.
Gosh, I've got to say, before David came up here, I said, you know, following Lee Daphne is a really hard act to follow, especially with that 30 seconds of 30 Rock. But I've changed my mind. Sherry is the hardest act to follow. I'm nowhere near as funny as she is, so I'm feeling bad right from the get-go. I'm also not a health economist. I'm a health policy guy, so I'm going to talk about this from this perspective. The Manhattan Institute, of course, is a nonpartisan 501c3 think tank, so I'm not endorsing any particular point of view here. I am market-oriented, market-focused, so I'll proudly say that. You know, one interesting thing to follow on Sherry's comments is there's an awful lot of path dependency problems in healthcare. You never really start at ground zero. You always start from where you are. And the stakeholders have a tremendous amount of influence on what gets done and what doesn't get done. And I think there's very little disagreement across the healthcare field that, let me see, that's not working, but I'll keep talking. There's very little disagreement, I think, that out of the $3.1 trillion or so that the U.S. spends on healthcare, there you go. Thank you. That the $3.1 trillion U.S. spends on healthcare every year, an awful lot of it's waste. The numbers that are thrown around are typically 20 to 30% of waste. So how do you get from the system that we all agree is incredibly wasteful and inefficient? You know, one thing I take away from Sherry's slide that showed the U.S. healthcare performance and cost versus other countries in the OECD is that some other thing is going on there. Because obviously we're spending a lot of money, but when you compare the healthcare systems of Japan and Sweden and all these other countries, and you see they keep going out on the curve, but they're so very different in diet and genetics and everything else. There's a lot of health that can not be attributed to the performance of the healthcare system. And that's good news and bad news. It's good news because it means you've got an awful lot of fat that you can cut. And it's bad news because it probably also means that your preferred view of the healthcare system probably doesn't really jibe with reality. So where Republicans are starting from, I think, is looking at the status quo today, the facts on the ground, and thinking of where they're going to be able to have opportunities to do what they think of as improving the current debate. Obviously, on the Republican side, you're going to hear a lot about repeal and replace. Let me just bracket that for a moment by way of saying that the political issues that any Republican president is going to face in 2017 are going to be at least, if not more formidable than the kind of situation that President Obama faced in 2008, because there are going to be 12 million people or 10 million people with coverage on the exchanges, 15 or 16 million people with coverage in Medicaid. I don't think the Medicaid state of play is really going to change much. I think Sherry's entirely right that if there is a Democratic president or any substantial change in the makeup of Congress, you'd see a bunch more states flipping. But from now, I don't expect any of those states that are still holding out, the 20 or so states that are still holding out, to change between now and January 2017, just because they're thinking, you know, if we get a Republican administration, we might get a little more flexibility. So what are we seeing? From the Medicaid expansion, 16 million new Medicaid enrollees. Obviously, for people who didn't have health care coverage, and this is something that I've always said, there are winners and losers under the Affordable Care Act, but if you are low income, uninsured, if you are someone who's had serious health issues in the past, you're clearly a winner under the Affordable Care Act. But I think there's also some interesting takeaways that we've learned in the last couple of years. And one of them is that the value of health insurance to this population is a little bit unclear. The Oregon Health experiment, a randomized experiment that randomized people either to get Medicaid coverage or not get Medicaid coverage, showed a couple of interesting things. One of which was that 2 years into the program, there were no measurable impacts on health outcomes except for, I believe, depression, which was remarkably quick. I think the outcome was within 6 weeks. And if you had a drug that showed that outcome in 6 weeks, you'd get right through the FDA. So that may have been attributed to the fact that it's reduction in stress. And of course, it's financial protection. That's exactly what we should be providing to this population, which is you should not be bankrupted by a series of or a single health event. Right? That's the really important part of any insurance paradigm, which is protecting you against those rare but very high cost risks. But at the same time, and Amy Finkelstein went on to do another paper very recently that said to the recipients of those Medicaid programs, the benefits are probably 20 to 40 cents on the dollar. And the reason she said that was those people were getting some care before, but it was being written off. They weren't paying that much out of pocket. So we're actually paying a lot more to providers for that population than before. So the value to the healthcare system is actually much greater than the value to that population. I think that's interesting because it also gets back to the question of waste and inefficiency. So if we think there's a lot more spread between what we're paying and the value that we're actually getting out of the system, I think that should lead us to a real open-mindedness about reforms that could really try to raise value and perhaps shift to more of an insurance arrangement that I think Republicans or conservatives would prefer, that's much more focused on catastrophic care. And then you've got the fiscal challenges with the program. Medicaid is about 30% of state budgets. That's both state and federal spending. After you subtract federal spending, it's about 18% of state budgets. It appears to be crowding out spending for things like education and transportation, probably some other things as well. You've also got to have questions about whether or not the federal government's going to sustain the 90-10 match that Medicaid new enrollees are going to start facing after, I guess, 2018. So eventually, the federal match is going to go down to 90%. There's a very slow recovery. States are fiscally a number of other fiscal challenges that make their Medicaid programs even more onerous. They've got enormous unfunded liabilities for other health care provisions to their employees. For instance, in New York, the New York NYPD pays more in health care and pension benefits for its retirees than it does for active police force members. So you've got hundreds of billions of dollars of unfunded liabilities, pension and health care liabilities that the states face. And I think you can see a fiscal crisis developing that might lead governors on both sides of the aisle to want to find better ways to spend the money that they're getting from the federal government today. And I think also goes to a number of interesting studies that have been coming out lately that show that there are other determinants of health for low-income populations. So maybe it's employment, maybe it's education, maybe it's housing, maybe it's supportive housing for someone who has addiction problems. We have silos in terms of how we're providing care through those areas, but it might make more sense to wrap that money around the person and give them a variety of different services into saying that one of the largest components of our spending has to be healthcare spending and has to go through Medicaid. So I think that's going to be a real focus of the Republican health care plans, is to look at better ways to spend our low-income safety net subsidy dollars, especially given the fact that Medicaid patients appear to have lower access to physicians, especially specialists, have worse health care outcomes for many health care conditions like cancer and heart disease. But this is certainly one place to start, a fiscal crisis and the realization that we could be delivering better health outcomes to the poor given the spending that we're making today. And the exchanges, and I think Sherry again did a great job of talking about the exchanges. This is another instance of recognizing the facts on the ground. The question, though, is, have we reached a peak right now? And I know the Obama administration recently tamped down their estimates for how many people are going to be in 2016. Now, I'm absolutely certain that there is an element of under-promise but over-deliver in those numbers, but they're clearly significantly down from what CBO is expecting even just 4 or 5 months ago. I think they're expecting 20 million as of 4 or 5 months ago. So I think you have to ask what exactly is happening on the exchanges. And then again, you're going to have cost concerns on the exchanges. One of the provisions of the Affordable Care Act is that if the cost of subsidies on the exchanges, and Sherry can correct me, grows faster, I think it is 0.5% of GDP after 2018, the premium tax credits are only going to grow at CPI. So assuming that we're going to see close to 6% healthcare cost growth going forward, you're going to see the premium subsidies on the exchanges growing more slowly. So people are going to feel that bite as time goes on. And I still think, there's so much more room to begin moving cost and quality information into the exchanges. President Obama, referred to a, Travelocity-like experience. I think there's still a lot of opportunity to deliver cost and quality information through the exchanges. But here's the real challenge. And the real challenge is a lot of people who are eligible for enrollment and even subsidies on the exchanges are not buying in. And Avalier put this graphic out a few months ago. And what's really interesting is that bar right there, which is 151 to 200% of FPL, only 41% of people who are subsidy eligible, and that's for cost-saving reductions on out-of-pocket payments that are pretty impressive. So if you're below 250% of federal poverty level, you're getting a pretty good deal, but there's still an awful lot of people sitting out the exchanges because the perception is, and again, this gets back to the value of care, the median amount of money you're going to be spending for the median person in America on healthcare every year is several $100s. It's like $700 or $800. So the question is whether or not for these people, for their year-in, year-out healthcare costs, is the potential cost of their premiums, net of subsidies, and any out-of-pocket costs that they would have to incur before their insurance takes effect. And deductibles for silver plans, I think, are around $2,500 thereabouts, and then obviously they go up for bronze plans. But someone could reasonably look at that and say, you know what, I'm actually going to be potentially better off taking the penalty and paying any out-of-pocket expenses I have this year, knowing that next year, if I have a serious health event, I can re-enroll. So a lot of those people I think are going to continue to sit out, and I think that's going to continue to be one of the challenges for the exchanges. Is the cost of coverage on the exchanges for particularly middle-income uninsured low enough to entice those people to buy and help make the risk pools on the exchanges sustainable in the long run? And I think there's some debate about whether or not they are sustainable. We're going to find out a lot more about that sustainability when 2 out of the 3 R's, the reinsurance and the risk corridors, go away in the next couple of years. So facts on the ground, ESI, I think there's probably almost no disagreement that the employer uncapped deduction for employer-sponsored insurance is a bad thing. I'm not an economist, but from all the economists I've talked to, there seems to be widespread agreement that that is just bad, and it's bad in a number of different ways. It's bad to tie insurance to employment. So if you lose your job, or if you happen to work at a firm that doesn't offer insurance, you have to pay about 30% on average more for coverage. It's bad because it's regressive, because if you make more money, you're working at a firm that's more likely to offer coverage, and you get more of a tax benefit from having it. So the way I find, the reason I find this deeply ironic is back in 2008, when Senator McCain was offering a standardized tax credit for health insurance, Senator Obama really made an effective attack on him to say, Senator McCain's tax plan is going to result in the taxation of health insurance for the first time. That's exactly what the Cadillac tax is. The Cadillac tax is a backdoor tax on health insurance. It's an effective cap on the tax. I think it's, government actuaries expect that probably by 2027 or so, 75% of US firms are going to be hit by the Cadillac tax. That's not necessarily a bad thing if you think that, there was a conversation earlier, I think at the table, about what exactly is it that insurance companies are doing to control costs. And, the way conversations about the value of healthcare in the U.S. tend to go is we tend to talk about it a lot when the economy's not growing and things aren't going well, and then it tends to be muted when the economy's growing and companies have more profits, and then we forget about it for a while. So there's an obvious advantage here to putting a cap in place that really forces employers, and I know they say that they do this, but I think that the reality is something very different, to say you have to have a conversation with your insurers and get much better information about the comparative costs and benefits of the health services you're purchasing. And you can really see this happening right now, and I'll say that that's one of the things I'll credit the ACA with. It has completely changed the conversations that are happening, not just with employers and their benefit managers, because everyone is really terrified of the costs that they would potentially pay starting in 2017. But it's changing union health plan conversations that you would not see before. So in New York State, Mayor de Blasio, who probably isn't one of the closest allies of the Manhattan Institute, you'd think, he got a contract with the teachers union that said, look, you're going to reduce the rate of growth for your health plan for your members, and we're going to split the savings. And we're going to put a hard cap in there. So I think those kinds of conversations, if you're a conservative or if you're right of center, you're thinking, actually, we want more of those kinds of conversation to happen. I also agree with Sherry that I don't think the Cadillac tax is going to go anywhere. I know big businesses don't like it. The unions obviously don't like it. But the fact of the matter is it has bipartisan support among economists. This is something conservatives have been arguing, conservative policy wonks have been arguing for an awful long time. I suspect that it stays there. But what I also think is going to happen as a political matter is I think the Republicans are going to look at this and they're going to say this is problematic because it actually taxes the 99% at the 1% rate. So you're basically applying the highest marginal tax rate, 40%, to any money that a person or the firm, but we know that the costs are going to be passed along to the employee, is going to incur for coverage above the cap. So why not move to a hard cap or some kind of hard cap and say, whatever, $12,000 for an individual, $30,000 for a family, whatever. Anything above that's just going to be capped as normal income. So there are lots of ways to play with that to get to deficit neutrality. I think if you want to lower the income tax rate, obviously, you probably have to lower the cap, but we can play with that and think about how that might work out. But I anticipate that being a Republican line of attack because it's a way of saying we want to be fair, we want to have a tax system that's fair, and we also want to get an even more transparent approach to what the Cadillac, to what capping ESI can do for the rest of the efficiency of the healthcare system. The real problem in healthcare, or at least from the Republican side of the aisle, people keep asking, where are the Republican plans? Where are the Republican plans? I hear that all the time from the media. There are no Republican plans. There are lots of Republican plans. There are tons of Republican plans. There are not a lot of Republicans who agree on what the plan should be. So that is the chief problem on the right that has really been a problem. My colleague Ovik Roy points this out a lot, and I think there's a lot of truth to this, is that for the Republican constituencies, they have health insurance. They're eligible for Medicare. They have employer-provided insurance. And I think, frankly, one of the weaknesses of the center-right thinking on this is just it hasn't paid as much attention to healthcare issues as the left has for an awful long time, and you're really just starting to see that changing now. But I think that's actually a good thing that you're really having both sides of the aisle agree, or not agree, but engage in a really thoughtful way about what it is exactly we're trying to achieve and what we should be doing. So just to recap, I think that the Republicans are going to focus on cost issues surrounding the exchanges. They're going to look at ways to make those plans more affordable, particularly for lower income Americans and middle-income Americans. They're going to look at fairness and safety net issues surrounding Medicaid and the Cadillac tax. And I think we're going to argue that current arrangements don't serve lower-income Americans very well in terms of access and quality, and that opportunity, both income opportunity and social mobility should play a bigger role in our safety net programs. And we shouldn't necessarily be spending all of our money on health if there are other determinants of health can actually improve the well-being of the poor, rather than sending our money to hospitals that are actually doing pretty well, even with Medicaid-level spending. And finally, innovation. I think that there are some good things in the ACA that are trying to push on bundled payments, patient-centered medical homes, et cetera, but I think that there's still a lot more that can be done to drive innovation at the state and federal level and get more competition into the healthcare system. I think Republicans are going to pay an awful lot of attention to that. So where the Republican plans are starting to converge, I think they're going to converge on a cap for ESI and then apply ordinary tax rates above it. As I said before, we're going to have to play around with that to whether or not we get to revenue neutrality. I think that we'll also pay a lot of attention towards moving some of the savings from choosing lower price plans into health savings accounts. I think right now the cost savings reductions, for instance, are pegged to silver plans. So why not let someone choose a bronze plan or even a catastrophic plan potentially, but savings into a health savings account? When you think of the amount of money that a typical employer is going to spend on someone over their working life, it's in excess of $1 million. It's probably $2 million. That money could be going into an account that an individual could be accumulating over time that could enable very, very substantial health care spending later in life, but would also draw far more quality information and cost information towards the consumer. In most other markets, people chase us to tell us what the price of their product is and what the quality attributes of the product are. There's, I think some disagreement, or there has been some disagreement whether or not that's possible in healthcare. I think, Ken Arrow is the famous, economist who won a Nobel Prize by way of saying, look, there are lots of informational asymmetries in the healthcare market that basically make it impossible for individuals to know as much about their healthcare, their own personal health needs and the quality of care versus their physician. But I think that's beginning to change. And I think that with new tools that are obviously becoming less expensive and more ubiquitous, electronic medical records, wearable devices, potentially genomic profiling in the next several years, if we become a little better at detecting who is likely to develop a given chronic illness, diabetes, cancer, you can begin to intervene earlier in the development of those diseases when treating them is actually much less expensive. So giving somebody a cancer drug when they've got stage 4 metastatic disease, you're going to buy a few months. If you're very, very lucky with a disease like CML, a version of leukemia that has a single molecular aberration, you can have a real tremendous impact. But catching a disease late is just very expensive. So innovation, I think, is one of the things we need to be paying a lot more attention to. Addressing the low-income challenges, and I think the ACA, really tries to do this. So it has premium subsidies, obviously, but it also has these cost-sharing subsidies. I think one of the challenges here, and it was the reason why I was shaking my head when Sherry was talking about whether or not we should automatically have preventative services offered without a copay. Take something like routine physician visits, a free annual physician visit. I'm sorry, Sherry?
It's not on the USPSTF.
All right, but it is covered under the ACA.
But not free.
I'm sorry. It's one annual visit that's covered. It's free. Is it Medicaid? All right. But those annual physician visits, and a lot of insurers cover them, don't really do much. If you don't have a serious chronic illness or some serious problem that needs the attention of your doctor, you don't need to see your physician every year. If you go in every year, they're probably going to find some things to do every year. So if we create more of a market by shifting more of this money into consumers' hands, we believe that we will engage more firms to chase us with cost and quality information. And again, more of that information can be made more routinely available through the exchanges. This is probably more controversial, but I think there's also going to be a look at deregulating the exchanges, or at least letting them go their own way. Maybe it's looking at allowing states to go to 5-to-1 risk rating, choosing less generous plans, or going to maybe making the baseline plan a high deductible health insurance plan with an HSA. But I think that that's going to be a focus both to bring down the costs of coverage on the exchanges and also, again, to get more engagement from the consumer about the cost and quality of the health care they're consuming. One thing I think, the individual mandate is really a lightning rod on the right-hand side of the aisle. I think it's probably one of the most contentious issues about the Affordable Care Act. I suspect that the Republicans are going to put forward a couple of different options, one of which are high-risk pools. That's been tried before. They, of course, were, for the most part, perpetually underfunded and somewhat problematic. What I would expect to see is an expansion of a basic idea like no risk rating if you maintain coverage. So basically, COBRA for everybody. So if you maintain coverage, you will not be re-risk rated if you develop a healthcare condition. That might be more effective than the current weak mandate in the ACA, which caps the penalty at 2.5% of income, I think, or $695 per family member, whichever is greater. But having that cudgel there, or that stick, the idea that if you don't maintain coverage, you could face a very substantial cost increase, might encourage more of those middle-income people to get into the exchanges and get coverage. There are other, flavors of this approach that you could try as well. Medicare Part D actually has, I think, a premium penalty for every year you don't enroll in the program. That might be another opportunity for thinking about better incentives to get more people, more of the young invincibles or healthy people into the exchanges. And then re-envisioning Medicaid. I think that probably Republicans and also, perhaps some Democratic governors, once you look at 2017, could look at the 1332 waivers and then wrapping them around 1115 waivers and having some broad conversations about giving states much more flexibility with how they design the essential health benefit plans for the exchanges, what they're going to tie coverage to, and how they're going to use their Medicaid spending potentially to wrap around it. So I think there's an awful lot of room, even without repealing the ACA, to go to a more federalist approach that would probably be attractive, certainly on the right, but possibly to some other Democratic governors who might also benefit from more flexibility. The reason is, this actually is very interesting. New York got an 1115 waiver where they capped their growth. I think it was at a 10-year moving average of 4% or so, which I think was about 2% below the trend before then. But the state is going to be on the hook for, I think, $8 billion in savings over 10 years that they've agreed with CMS on. And if they don't, they're going to have to come up with that money on their own. So I think that there's, a little bit of motion on the part even of blue states of really thinking about some innovative ways of retooling their Medicaid program costs. I think that will play into discussions on the 1132 and the 1115 waivers. And then again, Congressman Ryan proposed something called an opportunity grant, which would begin to bundle more of these low-income programs into a single block grant that could be used by the states. I think Republicans will drive that forward pretty aggressively, assuming that they take the White House. We had a terrific discussion on cancer drug costs today. I do think that one of the secret sauce for U.S. healthcare is going to be moving towards lower cost innovation. The open-ended tax treatment of employer-provided insurance and essentially, having uncapped Medicare spending has really led producers to produce high-cost products that might have marginal benefits, proton beam therapy, other products that are used at the end of life. We do lots of aggressive PSA screening for prostate cancers that may never kill anyone. So the system's incentives right now are really towards high-cost interventions that have high price tags, but not necessarily really outsized healthcare benefits. So what could we do to begin to encourage more low-cost innovations that deliver more bang for the buck? I think one way is to think about reforming the FDA's drug approval pathway. Whether or not you believe Tufts' numbers, that's $2.6 billion, maybe it's $1.2 billion, whatever it is, it's awfully, awfully expensive. If you look at the average weight of cost of capital for the industry, they're clearly paying a premium for that. So if you can bring the cost down and also change, we think, to pathways that are more molecularly targeted, that might allow you to go to market very quickly. Europe is actually testing something called a conditional approval pathway that's very similar to what MIT's New Digs is working out. But the idea is you have very good evidence, but in a very targeted patient population, you go to market very quickly, and then producers and manufacturers can have ongoing discussions about price as evidence about that product evolves. I think that would play very well with other reforms like bundled pricing, accountable care organizations, and other population health strategies that basically put producers more at risk for the health outcomes of the populations that they're seeing. Theoretically, at least, that could drive them to the most technologically efficient intervention rather than the most costly intervention. I also think that consumer engagement, and you can really see this in how it's playing out in the ACA, but also in other countries around the world right now. We are living longer. I mean, reflecting on the U.S.'s healthcare programs to date, like Medicare and Medicaid. Medicare in particular has been, astonishingly successful in protecting seniors from financial catastrophes. So it really has made seniors, rather than being one of the poorest groups in the U.S., actually if you look at them now in between 1965, children are actually, I think, now the poorest group in the U.S. as opposed to seniors. But the social welfare programs that have been employed in wealthy nations like the U.S. have really helped to extend expectancy, farther than we would have thought decades ago. And it's going to continue to do that. We're going to continue to face trade-offs between our pension programs, our healthcare programs, and the technology is not going to slow down anytime soon. So unless we're going to shut down the National Cancer Institute and the National Institutes of Health and the pharmaceutical industry, we're going to continue to be bombarded with new technologies that ask us to make trade-offs between cost and value. But the only people who capture the total value to themselves in this system is the consumer. The user of it ultimately is the one who has to make the decision about, at the margins, is this worth it to me? And moving more of those decisions to consumers helps producers retool to become more efficient, like they do in other parts of the economy. Interestingly, when you look at the U.S.'s performance in healthcare cost growth, we're about in the middle of the pack. We're worse than some, better than others, but we're not that bad. And healthcare costs tend to, again, be cyclical. So the economy grows, healthcare costs tend to grow, they slow down, they tend to slow down. Other countries like the UK, of course, they have a single-payer system. They tend to ratchet down payments for a while, and then there's an explosion of demand, and then inflation goes up again. But all of those countries, at least the wealthy developed countries, are facing the exact same problem, the exact same challenge. Aging populations, expensive, potentially life-saving technologies, and healthcare systems that are really based on assumptions that we made about 40 or 50 years ago. I think the train has really left the station for both parties. In this sense, if you were to say to Republicans, would you support an exchange-style program for people under 65, maybe you'd say, oh, the Obamacare exchange is not working, they're terrible. On the other hand, if you were to say to Democrats, would you support some kind of exchange type of approach, premium support for Medicare patients, you'd say, oh, no, that won't work, it'll be terrible. I think you're beginning to see a little bit of convergence in discussions about what exactly should be done. The rhetoric is very overheated, but if you were to look at some of Paul Ryan's reforms for the over 65 population and what the ACA has done for the under 65 population, you can actually see that there's beginning to be some convergence on some of the strategies we're going to use. I think we're going to continue to have debate around some very critical, very important issues and things that I would like to see go my way as opposed to a different way. But I think the U.S. is beginning to get to the point where we're understanding that the consumer has to be engaged. It has to be a competitive market. We're going to have a safety net for low-income folks, particularly at before the age of 65 and certainly after the age of 65. And we're going to have to retool the way that we pay providers. We no longer need to pay for volume, we need to pay for value. That train has left the station. I think employers know that. I certainly think providers have begun to recognize that, and the healthcare system is slowly beginning to change. I think one of the most interesting challenges we're going to have to grapple with over the next 10 or 15 years is, I think, two versions or visions of what healthcare should be. One of them is, we're going to spend whatever it takes, and we're going to get the best possible thing we can get, which is maybe the Lamborghini Veneno, which I think is one of the fastest cars on the planet. I think there are only 9 or 10 of them that have ever been built. But if you have the money to purchase it, that's great. Go ahead and buy one. The other approach might be to say, well, we're only going to pay for Camry-level care. And the Camry's a great car. It was Consumer Reports' best value in 2015. And if you can come down to the price of the Camry, we're going to purchase it. I think that's ultimately problematic too, because then you're essentially setting a price floor for consumers as well. We need to have a kind of healthcare system, I think, where we have consumers choosing among a wide range of choices and quality levels and asking questions about the benefits, the marginal benefits and marginal costs of those products, and putting much more price discipline on producers to meet those preferences. There are going to be people who are going to continue to buy the Lamborghini of healthcare and who are going to take risks at the margin. They may be the people who are using the cutting-edge cancer treatments where the benefits of those are unknown, or other approaches that might have to do with slowing aging, or some other, new technological approach that might be expensive but has very unknown benefits and possibly unknown risks. But there should be a wide range of affordable options for people who are in the middle, who can purchase them with their own and are going to be able to make those effective choices. What we haven't had right now are the price signals that allow those people to know what it is worth purchasing, and the savings that would allow them to do so for all but those truly high out-of-pocket expenses. And with that, I'll stop. Thank you.
Since you're in favor of competition, what are your objections to letting people under 65 buy into Medicare?
That's an interesting question. I think it's been posed a couple of times. I think the CBO's scoring of this, would it have saved money for Medicare because they get a younger population into that cohort? I think that the challenges facing Medicare have to do with the technology and the way that Medicare pays for coverage. So, absolutely. So for the people who are in Medicare today, who can go anywhere and buy any service they want, essentially, I think actually that's one of the problems with the program that we're trying to grapple with today. And we're trying to force people to make better decisions about what the value is. If you looked at the slides we saw earlier in the day about variation in Medicare spending across the states, we seem to see very wide variations in Medicare spending, but not variations in outcomes.
So Medicare typically takes the bill that they give and somehow divides it in half. So Medicare certainly has cost containment.
Medicare has cost controls. It has DRGs and other methods for controlling prices. I think that providers have also responded to those controls by shifting the mix and the utilization of the services they use. So I think that some of those controls have worked relatively effectively to slow growth, but at the same time I think providers have also responded in ways that have helped maximize their revenues, that I think have left them relatively untouched by the need to try and discipline their prices.
So I wanted to press you a little bit on the consumer-directed healthcare part. So this idea that we should have people have large health savings accounts, for example, and that would cause them to do more price comparisons. So there was one recent study I know of that I think is really the best evidence on this question, where they found a large employer who introduced a high deductible plan, and at the same time they also had a price comparison tool. And what they found is that introducing the high deductible plan actually did not induce people to shop around at all. It led them to cut back on their care. But for whatever reason, perhaps the asymmetric information one that you mentioned, people just didn't use the tool to find lower cost providers. So what that suggests to me, at least, is that just having more cost sharing, just having large deductibles or health savings accounts isn't enough, and that you need some other way of helping people utilize these tools to make better decisions, because they just can't do that on their own.
Right. I think we're still at the early part of that. I know that there was another study I think Castlight did that looked at what happened, for instance, the search for diagnostics. And there they did see people change their behavior when they saw, oh, here's the price for this given diagnostic procedure. I can get this less expensively somewhere else. And they did change behavior at the margins.
So I think there is evidence that when you introduce a price transparency tool, that can work. But I don't think there's evidence other than what I talked about the interaction between the price transparency tool and cost sharing.
Okay.
Yeah, so single-payer advocates always look north or look to the United Kingdom as a model. Are there any countries that you would look to and say this is the United States health care system should become more like this?
It's an interesting question. I think that the U.S. system de facto is starting to look more like Switzerland I think that's probably the closest analogy to what seems to be happening in the U.S. healthcare system now. That's not necessarily a bad thing from my point of view. You do have lots of consumer choice in Switzerland. You do have relatively good healthcare technology, and you also have health savings accounts. So I think that probably the U.S.'s commitment to probably innovation and technology and market-driven competition is going to keep us relatively along that course of a country like Switzerland, or a country, obviously a much larger health savings accounts than we do, but also a very different population like Singapore. But I would think that that would be the direction we'd be evolving in.
Since you're a PhD in political science, I can ask you some of the more political questions that economists are unable to answer. You know, it seems like every presidential candidate is really out to repeal part of the Affordable Care Act or all of it, and I think it's really interesting that you mention some options for not repealing, but fixing the parts that you know may not be working quite right. And do you think and I'm surprised how early we are on the election cycle, and you know these candidates are giving specifics. Do you think that will change? Do you think we'll get a little bit more sanity from the presidential candidates as we move on, or?
You know, I think that, look, there was the discussion, I think, earlier about the Supreme Court decisions. I think that, you know, from a political point of view, the Republicans were waiting for the court to save them in some respects, honestly. So I think that, you know, the discussion is, I think, becoming more nuanced. I think if you look at Senator Rubio's, I mean, he hasn't really done much of a plan, but if you look at Governor Bush's plan, what Senator Rubio has outlined so far, what others have offered, I think the discussion is moving forward. And from a political perspective, if you are the president in 2017 and you're looking at the tools that you have at your disposal, are you going to be able to get repeal and replace through the Senate with 61 votes? That's still going to be an enormous challenge. And I think, you know, you're going to look for opportunities to really help people. I mean, do people really care at the end of the day if you were going to have a full repeal and replace strategy, if you know, that means that there's, you know, going to have to wait this long fight and they're still facing very high premiums on the exchanges. You know, so I think that the necessity of facing some very pragmatic challenges is probably going to drive the conversation forward, you know, especially a year or two from now when the presidential furor has kind of died down and you get to have a different perspective on what's exactly needing to be done.
So just to follow up on that question, do you have any idea sort of which economists are talking to the Republican candidates? I'm just curious, you know, I thought you might know because, you know, I'm not privy to that information.
You know, I don't really talk to the Republican campaigns, so I know that there were, you know, when I was working with Governor Romney a few years ago, there were economists on his team. So I don't know who the ones today are, just because I haven't been talking to the campaigns at this point. Great, thank you very much.
Thanks very much, Paul, for making sort of just giving us a very nice background about what's going on and giving some very, I thought that was a very comprehensive discussion of the possible alternatives that we can consider as we're moving forward. So I think that's going to be, I'm going to be saving your slide deck to sort of look back on that and see, you know, for ideas and see how we do going forward. So this brings us to the end of the day, and I thank you very much for staying with us and asking some terrific questions and participating. And again, if you can fill out the form, we really appreciate it. Once I get to this day, I mean, there's really, other than getting some terrific speakers to come, and thank you very much for to our speakers for giving some great talks and covering a lot of ground. I appreciate this caliber of speakers coming to Houston and talk to us. But really, you know, all I do is I get together the panel, and there's this crew at the Baker Institute that does all of the work. And I'd like to thank them. We've got a whole group in the audiovisual section back here who's been making all this work today, all the technology, and our event staff who took care of our RSVPs and the meals and the food, and Brenda Laymance, who has coordinated a lot of this particular conference for us. She's our program coordinator at the Center for Health and Biosciences, and Mara Short, who may or may not be here. But I'd just like to take a minute to give them a hand. So thanks very much. I hope you have a good weekend. Feel free to give us comments and feedback and what you think about this, and we look forward to having you come to our other events and hope to see you again in 2 years. Thank you.